Welcome. This presentation, entitled Breast Cancer Prevention, a Program for the Population-Focused Nurse, was prepared by Hermione Krieger, Stephanie McHenry, Kennon McCollum, and Catherine Martin Bradle as part of the requirements for Nursing 735, Population Health for the Advanced Practice Nurse at the University of Alabama Capstone College of Nursing, Spring Semester 2012. The objectives of this program are to provide the viewer with basic information about breast cancer in America, explore the various health risks that are associated with breast cancer, explain the differences between primary, secondary, and tertiary prevention measures in regards to breast cancer. In addition to those objectives, this program will explore a secondary prevention program entitled the Find It First program. It will discuss the interdisciplinary nature of the Find It First program, as well as the interdisciplinary approaches to various types of breast cancer care. It will also explore leadership competencies that are necessary for the DMP in regards to the program, and will discuss data that will be used to evaluate the program and the program interventions. Breast cancer in women continues to be a major health concern for the United States. In the year 2012, the American Cancer Society predicts that approximately 226,870 new cases of invasive breast cancer and approximately 63,300 new cases of carcinoma in situ of the breast will be diagnosed in the U.S. At current incidence rates, approximately 12%, which equates to approximately 1 in every 8 women in the United States, will develop some sort of invasive breast cancer within their lifetime. Even though there has been a decline in the incidence of newly diagnosed breast cancer of approximately 2% from 1999 to 2005, breast cancer remains the second leading cause of death in women and is surpassed only by lung cancer. It is estimated that there will be approximately 39,510 deaths from breast cancer in the year 2012. Women who are at most risk of developing breast cancer are those who have an inherited familial risk, such as deleterious mutations in either the BRCA1 or BRCA2 gene, are Caucasian, are obese, are over the age of 55, are exposed to certain environmental factors, and those who have had previous hormonal replacement therapy. Also, women who have had early menarche, later delayed menopause, nulliparous women, and those women who have strong family histories of breast cancer are vulnerable to the disease. Differences in race and ethnicity influence a woman's likelihood of developing breast cancer. Caucasian women are more apt to be diagnosed with breast cancer than are African American, Hispanic, Latina, and Asian women. Unfortunately, African American women are usually diagnosed at an earlier age and typically are diagnosed with a more aggressive or more advanced stage of breast cancer at the time of their diagnosis. In examining female breast cancer from 2004 to 2008, it is noted that the median age at the diagnosis of breast cancer is approximately 61 years of age, and Caucasian females were diagnosed at 124 cases per 100,000 women, as compared to 119 cases per 100,000 women for African American women, 94 cases per 100,000 for Asian women, and 92 cases per 100,000 for Hispanic women, respectively. In looking at relative trends in female breast cancer, it is noted that from 1998 to 2007 in the U.S., the incidence of invasive breast cancer has declined by 1.3% per year amongst all women, has declined approximately 1.4% per year among Caucasian women, has remained relatively unchanged among African American women, has declined by 0.9% per year among Hispanic women, and declined approximately 1% per year among American Indian, Alaskan Native women, and has remained unchanged among Asian Pacific Islander women. Trends as they relate to mortality or death from the disease from 1998 to 2007 in the U.S. show that deaths from breast cancer have declined 2% per year among all women, declined approximately 2% per year among Caucasian women, declined approximately 1.4% per year among African American women, declined 1.9% per year among Hispanic women, have remained relatively unchanged among American Indian, Alaskan Native women, and have declined 1% per year among Asian Pacific Islander women. Contemporary breast cancer care has changed. It has changed from a typical model of fragmented and episodic care to a more comprehensive team approach. This comprehensive team approach is typically characterized by ongoing communication, active information sharing, and multiple disciplinary collaboration and interaction. This collaborative, multidisciplinary team approach often includes primary care providers, surgeons, oncologists, radiation oncologists, specially trained oncology certified nurses, advanced practice oncology nurses, social workers, patient advocates, and genetic counselors. Advances in screening, diagnosis, and treatment, combined with an expanding armamentarium of new and efficacious chemotherapeutic agents, often mandates that a multimodal and comprehensive care model approach to cancer care is followed. Consensus planning conferences regarding patient care allows various disciplines and providers to share their expertise and offer patients the advantage of multiple options regarding their cancer care. According to Rabinowitz, 2004, ongoing communication among various providers and a comprehensive care model approach to care often leads to better patient outcomes and a higher level of patient satisfaction. Advances in reducing mortality in breast cancer are related to improved screening, diagnosis, and treatment efforts. Integrated collaborative team approaches among multiple disciplines who engage in ongoing communication and active information sharing has led to improvements in the care of this disease. The goals of cancer treatment are simple. They are to eradicate disease and prevent recurrence. Health risk associated with breast cancer is the ultimate mortality if the disease is left untreated. But patients who experience the cancer continuum are often riddled with pain, fatigue, alterations in body function, and emotional discourse. Emerging trends in breast cancer care are centered around the reduction of these health risks. They are also centered around improved screening, earlier detection, and genetic susceptibility testing. And most recently, there has been a shift in focus of care to include issues related to cancer survivorship. Preventing breast cancer is typically easier and less expensive than curing breast cancer. Primary prevention focuses on risk reduction and changes to the environment that reduce cancer-promoting agents. Frieden, Myers, Krasakoff, and Farley, 2008, proposed that two important actions for primary prevention of cancer in general are the reduction of tobacco and alcohol exposure. Coastman and colleagues further postulates in 2011 that obesity is also associated with many cancers, including breast cancer, and estimates that 90,000 cases of cancer per year could be prevented if excessive caloric intake and obesity could be reduced. Yana Yakowitz, 2010, reported that declining trends in breast cancer was also noted in particular cases when the intake of vitamin D was greater than 800 international units per day. It has been hypothesized that vitamin D has the ability to help prevent gene mutation and ultimately may reduce the risk of breast cancer. The role of vitamin D in breast cancer prevention is not yet known, but ongoing research suggests that vitamin D supplementation may be a good preventative strategy. Deleterious mutations in the BRCA1 and BRCA2 genes have also been associated with increased breast cancer risk, so early detection of these mutations in high-risk women, combined with prophylactic mastectomies and/or prophylactic oophorectomies, have been proven to be effective and primary prevention measures for breast cancer. Secondary prevention reduces cancer mortality through screening efforts, early detection, and early treatment. The first lines of defense in screening are self-breast exams, clinical breast exams by trained healthcare providers, and follow-through with recommended mammography. The United States Preventative Services Task Force recommends annual screening mammography for women ages 50 to 74 years of age and biannual screening for certain high-risk women. Recent controversial decisions by the same agency concluded that current evidence is insufficient to assess the additional benefits and/or harms of screening mammography in women over 75 years of age. This remains a currently debated topic and is left to individual provider and patient choice. Breast cancer has also been well documented as a common secondary malignancy in survivors of many childhood cancers like Hodgkin's lymphoma. Those who have been treated with radiation for childhood Hodgkin's disease have a higher risk of developing breast cancer than does the normal population. These women should be considered high risk and undergo more rigorous screening efforts if they have a history of childhood cancer, childhood exposure to chemotherapy, and prior radiation to the chest area. Family history of BRCA1 and BRCA2 mutations are also strongly associated with breast cancer. When discovered in women who have a breast cancer diagnosis, this data may guide surgical interventions such as contralateral mastectomies and/or prophylactic oophorectomies in order to prevent cancer recurrence. In this situation, genetic testing is considered to be a secondary prevention measure. Tertiary prevention measures focus on the interdisciplinary aspects of breast cancer care. This includes measures that focus on advanced treatment modalities, professional development of disease pathways, and continued scientific inquiry in the area of breast cancer research. Progress can be made in all approaches, but will require a greater emphasis on public health forums that facilitate interdisciplinary care teams, while public advocacy for breast cancer issues continue to remain the earmark for funding for the development of policy that directs greater screening, treatment, and follow-up care for breast cancer. Healthcare teams are not new. Dating back to the 1940s and the early 1950s, physicians Martin Shirosky and George Silver advocated a team approach to delivering primary care services. In their approach, the physician, nurse, and social worker work together caring for families, emphasizing health services and prevention. The disciplines involved with the primary and secondary prevention of cancer include the primary care provider, the gynecologist, radiologist, nurse practitioners, and various other patient-focused groups, governmental agencies, all with a focus on promoting health care and preventing cancer. The coordination of treatment for the newly diagnosed breast cancer patient can be challenging, especially in a private healthcare system. The process begins with an effective imaging program built upon trust and seamless coordination among breast radiologists, referring clinicians, and treating physicians. Multidisciplinary breast care models facilitates direct communication between multidisciplinary breast conference participants and the patient. All medical specialties involved in the treatment of breast cancer, including many ancillary and support providers, come together to consult with the patient in a one-stop shopping type of an appointment. The purpose of the clinic is not to just provide treatment plan, but also to educate and offer support for the patient. It also assures that the patient has her providers communicating well with one another in regards to all of her treatment. This type of service, in addition to being the right thing to do, sets a healthcare system apart in the competitive world of the cancer market. Our proposed breast cancer prevention program is a secondary prevention program entitled the Find It First program. This program targets high school senior girls, college-age women, and other various women throughout the community. The goal of the program is to teach the importance of self-breast exams as the first line of measure for discovery of early-stage breast cancer, and to teach the importance of mammography screening to women in various settings. The program also will identify high-risk women who may need early mammography or referral for genetic susceptibility screening for the BRCA mutation test. Secondary goals of this program will be to identify women who are high risk for genetic susceptibility to BRCA1 and BRCA2 mutations, and to identify cancers at an earlier stage through early detection by self-breast exam, and to increase community mammography compliance. It is hoped that these interventions will improve community health through early detection and early intervention on identified cases of noted breast cancer. The program will consist of trained volunteer community nurses and community nurse practitioners who will provide age-appropriate 1-hour educational workshops for either high school senior girls, college-aged females, or women throughout the community. Discussion points within these sections will include information about breast cancer in general, the importance of monthly self-breast exams, age-defined discussions about when to have mammograms, and will provide information to the audience as to whether or not they may or may not be high-risk women for breast cancer related to either a strong family history or the possibility that they might have a suspicious case for having either a BRCA1 or BRCA2 gene mutation. Appropriate community referral pathways will be established for those at high risk. The program will work closely to provide interdisciplinary collaboration with local primary care providers, local mammography and genetic testing facilities, local oncologists, local wellness providers, and local surgeons to provide support to those who test positive for breast cancer findings upon examination. It is our hope that this program will influence community health by improving self-breast exam compliance, improved mammography compliance, and will ultimately lead to earlier stage detection of cancer within the community, which ultimately will lead to better outcomes in terms of cancer within the community. The Find It First program will provide oral presentations, demonstrations, and written materials. The program will be staffed with nursing students, nurses, and advanced practice nurses who are skilled in doing breast exams and who are more than capable of demonstrating these techniques to others. In addition, the program will provide written and practice instructions on how to conduct self-breast exams, information on mammography, and information regarding BRCA testing. The sessions will allow participants to demonstrate on a mannequin the proper procedure for doing self-breast exams. The program will also provide calendar stickers to each woman to put on their home calendars to remember when to do their monthly self-breast exams. Contact numbers for local breast prevention services will also be made available. The program will refer any high-risk women identified to have a genetic susceptibility to local genetic counselors when high risk for BRCA mutations are suspected. Also, we will have referral pathways in place for women to follow up with mammography and follow up with local providers for any participant who discovers a lump during the program. In order for the Find It First program to be successful, it must be a truly interdisciplinary effort between program staff and program participants. Participants must understand and believe in the program's benefit to their own personal health. Participants within the program must also continue with self-breast exams and mammography when indicated on a compliant and regular basis. There must be good collaboration between staff members of the program team, and most importantly, these team members must coordinate and collaborate follow-up care with local area mammography facilities, genetic counselors, breast surgeons, and oncologists when a patient is identified in the program who may have an active undiagnosed breast malignancy. Change is not an easy thing for humans to do, and it often takes a leap of faith to adopt the unknown with the promise that their health or situation will improve. Schuler, 2003, summarizes that excuses are often given as to why people do not want to change, and also states that in order to win people's commitment for change, you must engage them on both a rational level and an emotional level. Sebastian, 2012, summarizes that in order to effect change, nurses must exhibit the skills of good leaders, which include effective interpersonal, political, organizational, physical, analytical, and informational-based competencies. Michelson, 2011, states that the leaders of the future will need a host of new skills and competencies if they are going to succeed. In order to successfully develop and implement our Find It First program, two main DMP leadership competencies are required. Those are the competencies of empowerment and delegation. Sebastian, 2012, summarizes that empowerment is ensuring that knowledge and skills are available to make decisions. The advanced practice nurse not only empowers the team to provide better client-centered care, but also empowers patients, patient treatments, and their ability to enact upon their own disease. It is this ever-changing healthcare climate that makes it more important than ever that the advanced practice nurse be able to delegate. Sebastian, 2012, also explains that delegation is ensuring care that is appropriately coordinated and done in a manner that concomitantly develops the team member's skills and talents while also improving their job satisfaction. We will use delegation in our prevention plan, screening plan, and diagnosis plan in order to treat the most participants as possible within the Find It First program. The Oncology Nursing Society, 2003, cautions that the advanced practice nurse must delegate, but they must also be up to date with their state laws, regulations, guidelines, and specific facility regulations to avoid being held responsible for either delegating a task that should not have been delegated in the first place, or for the failure of the advanced practice nurse to adequately perform the delegated task. The advanced practice nurse is ultimately the one responsible and accountable for delegation. In order to evaluate the effectiveness of the Find It First program, we must first know what baseline data exist. What are the breast cancer rates in the area, and are these rates increasing or decreasing? This can be accomplished through analysis of data from the National Cancer Institute's Surveillance, Epidemiology, and End Results Report. This is a national cancer database registry that houses population-based cancer statistics. By using analytical software from the National Cancer Institute, called the Cancer Survival Analysis, or CANSURV software, and the Complete Prevalence software, otherwise known as COMPREV, county statistics on breast cancer diagnosis, and breast cancer incidence rates can be analyzed to determine the program effectiveness. It is also important to know what programs exist in the area and if they are effective. If they are, what are they doing right? If they are not, what are they doing wrong? In particular to our interventions, we would want to know how many women in the area are performing self-breast exams. It is also helpful to look at information from other communities as well. Once the program is in place and deemed to be successful, Schuster 2012 states that only the meeting of objective and the effects of the intervening activities have to be assessed. In addition to these factors, the cost of intervention in time and money must also be evaluated. In summarizing, breast cancer and programs aimed at improving care for this disease remain important, as this disease continues to be a major health problem for women and remains the second leading cause of death in women. It is crucial that we recognize that healthcare disparities continue to be problematic for this disease, despite the fact that incidence rates for this disease are declining. Primary prevention measures, as well as secondary prevention measures, continue to improve the incidence and mortality rates associated with breast cancer, and interdisciplinary approaches to breast cancer care have improved outcomes and should remain the model of care. Early intervention has been shown to improve patient outcomes in breast cancer. Secondary prevention measures include breast cancer screening initiatives such as self-breast exams, mammography, and BRCA testing. The Find It First program is a secondary prevention program that focuses on self-breast exams, mammography, and BRCA testing that will hopefully help to fight cancer at earlier stage and allow interventions to occur sooner. Surveillance, epidemiology, and end results SEER data, along with community assessment, can validate the success of the Find It First program. Empowerment and delegation are DMP-specific competencies by which program success can be enacted. Thank you, and we hope you enjoyed our program regarding breast cancer.